Thank you very much, Madame la Présidente, and thank you for making this session happen. Well, we discussed a lot with my co-chairs about what could be an optimal study design. And the question rose about, should we do a randomized controlled trial, or should we do a before-after study? So let's go through that and look at the reality. The reality is that we want to provide new knowledge. And by the way, to be able to be conclusive, we need to have a good study design. We can be either observational or interventional. And here, the study was to evaluate a new device with an intervention. So that being said, we are out of the observational studies. We are in the interventional studies. They are usually prospective. And it's usually specifically tailored to evaluate the direct impact of one treatment. Of course, each study has different outcomes according to what we are thinking and what we want to convey. The most common interventional study is a randomized controlled trial, but we are very far from thinking that it's only strength, and they are, of course, backwards. The drawbacks. So we know that there are the pre-post studies that are not in the randomized controlled trials. There are the non-randomized controlled trials, and there are the quasi-experiments. And what we want is to evaluate something that is really precise, that can be either a treatment or a prophylaxis, things like that. So you can see here that we have the pre-experimental design, the quasi-experimental design, and the experimental design. In the pre-experimental, you have only one group. So it's only post-test or pre-post test. The same group is going to have two different interventions, and we are going to compare outcomes in a kind of crossover study. In quasi-experimental studies, we can either have post-test only with no equivalent groups, or pre-post test with no equivalent group, which is, let's say, a non-controlled pre-post study. And you have the experimental with equivalent groups with post-test only, pre-post test with equivalent groups, which involve a control group and a randomization. And of course, we consider that there are different indications for the different experiments. Of course, in the pre-post, we have the confounders. You can imagine that you do an intervention, but the two groups, for example, could be very different. We can see, for example, mortality in patients with severe COVID-19 pneumonia. Mortality was very different between the different waves, and if you were doing a pre-post study, you would not be able to compare outcomes in this setting. And of course, randomized controlled trials are also subject to selection bias, and this is why the external validity and the internal validity depends a lot on how your inclusion-exclusion criteria are going to be sound. So we really need to pay attention to every study design. So Samir presented us with a pre-post study. So we measure the occurrence of an outcome, by the way, oxygenation outcome, before and after a particular intervention is implemented. Pre-post study may be single arm, so you take the same patients and you have an intervention and then you remeasure outcome. And it's very interesting that you could also have two different groups, but by definition, it's not controlled, and the two groups are not going to be 100% comparable. And often, this is the case that Samir presented. We have a multi-arm pre-post study with different groups of patients undergoing the interventions. And by the way, for intubation, it's obvious that patients undergoing surgery are not going to be normally to be re-intubated in the following days. So this is why the two groups are different, and we don't have a randomization, but we have a multi-arm study. The strength is obviously the temporality, because you really control what you observe, and you cannot control the rest, and there are many elements that are confounding. Outcomes measured for pre-post usually are binary, like incidence or prevalence here of an oxygenation parameter. Sometimes it can be a continuous variable with a mean value. But it's not so easy in pre-post study. And of course, the analytic method is specific. This is a pre-post study with no intervention, but just with different groups, with the same group of patients. So there is only one group, but we are going to compare health, global health, before and after an ICU stay. So we are comparing one group of patients, and the intervention is the ICU experience. It's a pre-post study. If we are going to this study, we are comparing COVID-19 patients before their health, before COVID-19. Of course, it was a self-reported health as compared to after COVID-19. And you can see the number or the percentages of patients having new onset of symptoms. This is a very good frame to be able to compare the same patients before and after a specific experience. Before it was the ICU experience, here it was severe COVID-19, but not all of them were in the ICU. So, of course, we are looking for immediate impact of short actions. We are not going to have long-term outcomes in pre-post studies, or we would need to design them as very two parallel cohorts, and it's not so easy, because if you have only one group, the two long-term outcomes will affect the same group. So it's very important that we are able to demonstrate an immediate impact. So this is why this study was really designed to be a pre-post study. Of course, there are many different biases. One is the history bias. Of course, you need to have a history. Then is the validity of the measurement, and this has been a lot discussed in these specific studies. The problem of the regression to the mean that affects every research study, the testing threat, because the measurement may have an effect on the outcome, the placebo threat, the Houghton threat, the maturation, and the dropout that also exists in before-after studies. Now, all of you know very well the randomized control trial, and we know that we are taking one group and we split it in two, sometimes three, sometimes four, and we are going to have different interventions in the different groups. So the different interventions in the different group make the trial controlled, because you have a control group for every intervention, and you have a randomization. Of course, the largest strength of our cities is the randomization. And even we can say a lot on whether we have a control group or not, but randomization makes it really almost perfect. Or if it's not, you can question on other things. But we know that there are other strengths, like, for example, allocation concealment, which is really a strength, blinding when it's blinded, measuring compliance with the interventions, controlling for co-interventions, measuring dropout, analyzing the research by ITT, which really makes it also, I would say, pure. And of course, you can assess each treatment arm at the same time point based on the study design. Of course, we know that when we have an RCT, we can compare, we limit the biases, we limit the number of confounding factors. We have a very reliable statistics, because it's very simple, and the more it is simple, the more it is reliable, and it's very easy to publish. Every journal dreams about publishing an RCT. But there are problems with the logistic. Should we have done a randomized controlled trial for this study? Well, I'm not sure. Not only that the sample size would have been very different, that the validity would have required maybe more than 4 sites, which is difficult to manage in a research time. So you are taking a long time to bring evidence at the bedside, which can be a source of criticism. Also, there is a long trial runtime, and sometime at the end of the trial, the clinical question that really rose the trial is outdated. The statistics, so there's the problem of the blocks of randomization. So you can sometimes guess what is going to be the arm where the patient will be. Applicability, as we are putting a lot of purity in the clinical question, we are then having a problem with inclusion and exclusion criteria, making that maybe at the end the RCT will not apply to the bedside. And of course, there are ethical limitations about all of the things that we have to do, because the pre-post study is only a cohort with an intervention in the middle, staying in the standard of care. Well, many of the journals are criticizing, and I like very much this editorial in Emergency Medicine Journal, and this editorial is very critical about the Cochrane that discouraged to do pre-post studies. And by the way, if we want to bring evidence at the bedside, we cannot publish only randomized controls trial. So of course, there are all the drawbacks that we mentioned about the pre-post study, but it's still fine, and they say, we want to compare them. I would give two more messages. One is how much we overestimate the impact of an intervention with a pre-post study. This is the classic example from our colleagues from Germany, and they provided a before-after study on patients with CPR, not from asystole, but from cardiac origin, and they did what they say, well, it is mostly about myocardial infarction and pulmonary embolism. So let's test the effect of thrombolytics. So they did a before-after study, and it was very clear that in their study, there was a benefit. But we know that we overestimate the hypothesis by doing such studies. So the same group was honest enough, and in a very nice paper, they provided the evidence that thrombolysis during CPR not only didn't bring any advantage in clinical outcomes, but also was associated with an increased number of patients with brain hemorrhage. So by the way, sometimes you can bring evidence at the bedside discussing the benefit and the harm of a specific study design, but then when the result is impressive, you still need to report it in another study. It can be a very long cohort study with long-term outcomes that would bring more evidence, or it could be another randomized controlled trial, but then you need to start preparing the RCT at the time you are publishing the other one. So controlled before-after studies is the other way, and this is my last message, to address that. So that would be a mix between the before-after and the RCTs. So what it is about? It's about randomizing patients. No, we consider that maybe there is, for some of us, some issues with randomizing patients, so we are going to randomize centers. But instead of having centers yes and centers no, we are going to have all the centers undergoing the intervention, but at different times. So we are not randomizing whether the center is action or no action. We are randomizing when the center will start being interventional. This is the step-wedge randomized controlled trial. Of course, there is an intra-class correlation making that it costs a certain number of patients. And we need that. This is an example of antibiotic consumption. We know that we are having different results, and this study was very interesting. But I would say that instead of comparing RCTs to pre-post, we could consider doing step-wedge randomized controlled trial by bringing the time of exposure to the evidence. It's very pragmatic. And of course, you are not having a parallel cluster like in the upper part of the slide, but you are going to have a step wedge. So you are going to estimate when the patients are going to start the intervention. It's a before-after study, but with a randomization of the time when patients in each cluster are going to be part of the intervention. It costs patients. So you are going to have much more patients in this kind of RCTs than in the classic or in the parallel cluster RCTs. Because of the intra-class correlation, you need to increase to keep the same power. My last message. Any option that you have decided to do, then you need to sell your paper. And I congratulate the authors of this paper, Samir, Audrey, Danny, and all the group, for really having sold the paper in a very good way. So now, not only you need to do a clinical study, but you need to take it very quickly at the bedside and appropriately, not emphasizing a result that is a doubt and not giving less importance to any of the data. So you need to then bring your paper to PubMed, and for that to happen, you need to follow the Equator guidelines for really publishing in the best way. Thank you very much.